have short presentations by both of you. So Greg, I'll invite you first to speak, and then Dr. Abdus Salam, I'll invite you to speak. I'm hoping that the talks will be over before we reach 8:30, so around 8:30 or a little before that. And then we will open it up for question and answers, because we call it dialogue. So I like to have that discussion going. Traditionally, we have used in IBM chat room. But this time we have opened it up directly on Zoom, which will allow people to either write their question in the chat box, or they can also raise their hands and log, ask the question directly to one of the two of you. So my request is to keep the answers to somewhere between 60 to 90 seconds, so we can allow more questions in the process.
That's fine, that's fine.
Yeah. We have, and I was telling Abdus Salam, Dr. Ciottone, that we have had between 100 to 300, usually around 2 to 50 participants in every session, and from about 8 to 10 countries.
Okay, that's good. That's good.
Yeah. We're going to, so far, most of our, as you know, speakers are either are from US and Pakistan, but I think in the next few sessions, I'll try and get our colleagues from East Africa also involved, and in other parts of the world. Abdus Salam, how's COVID at the Shifa?
It's coming. I would say probably for us the game has started, because I will tell you 10 days ago we hardly had any patient diagnosed with COVID and admitted in the hospital. But as for this morning, we had like 26 patients, and about like 15 of them were in critical care. So it's coming, and every day we are seeing people who we are diagnosing or already diagnosed coming up with different symptoms. Most of them respiratory symptoms, a couple of them with diarrhea and abdominal pain and stuff like that. We are just hoping that it would not go beyond our limits. So far we are able to manage, and we don't call it any disaster or any other situation. Although the ER is the center of attention, so we never had this much attention in the entire span of my being an emergency physician. So everybody is looking what we have to say in everything. But that's a big challenge from the other aspect, because everything sort of started shoving down to the emergency department. Oh, this thing, well, ER will do it. That thing, the ER will do it. And we have to keep telling people, don't let us exhaust. Otherwise, then you have to come and do our part. So if we are managed properly, and if our resources, our manpower is kept at a level that we are able to function, then everybody else will stay safe. Otherwise, you have to come and work where we are working. So so far, it's doing all right.
Yeah, ER is, when you need it. Do you think it's going to the importance of the emergency medicine in Pakistan is continue to be like this once this is over?
Well, the thing is, you would see it in my slide. One of the points that I have tried to highlight is that it depends upon us rather than depends upon Pakistan. It depends upon us that how we can keep the momentum going, and we be able to cash this attention into a meaningful asset for ourselves for times to come. So if we can cash it well, probably we're going to get the break that we always wanted, that you always wanted. And I know that the struggle that we all started like 10, 15 years ago, we are hoping that we're going to get the mindset finally changed about the emergency medicine in the minds of most of the Pakistanis, especially the people who are the decision makers or the stakeholders of the emergency departments across Pakistan. So how is the weather in your side of the world?
It's beautiful. It's very, very nice. It's amazing, nice.
You know, and the same thing I can tell about almost about Islamabad. It was raining yesterday, and it was not quite May this year. I don't know how, but somehow. Although I know the Karachi is about to face another challenge of heat wave in the midst of COVID, and I think they have predicted somewhere around the 8th or 9th of May that they probably may be seeing a temperature around 42 degrees.
All right, so we have a couple of minutes before we start. So let me get everything set up. And we have a few participants, attendees already. So I'll have you share your screen for the presentations. Okay.
Sure.
Okay, good morning. We have some people who joined us. Let me start by welcoming all of you to the 7th COVID Dialogue. This is a series that we started several weeks ago that talks about various issues that the health systems and individual healthcare providers face in taking care of patients with COVID-19. As you know, pandemic is continuing to have huge unfortunate impact on the health of individuals. It is also weakening the health systems in many parts of the world, some better than others. And we continue to get, personally, I can say, continue to get challenged by the amount of information we have and trying to sort out what works and what doesn't work. But one thing I know that has made a difference in how regions and countries have responded is the leadership. And today we are fortunate to have two outstanding speakers who are going to be speaking to us, as well as after their initial presentations, talking to us and answering your questions about leadership. So I'm going to quickly introduce the two panelists, and then we can have their presentations. The first presenter is Dr. Gregory Ciottone. Dr. Ciottone is the president of the World Association for Disaster and Emergency Medicine. He's an associate professor at Harvard Medical School and an instructor in the Department of Health Policy and Management at Harvard T. Chan School of Public Health. He is the founder and director of Beth Israel Deaconess Medical Center Fellowship in Disaster Medicine, the first of its kind at the Harvard Teaching Hospital, and the medical director for the National Preparedness Leadership Initiative, a joint program of the Harvard School of Public Health and Harvard Kennedy School of Government. He also serves as a consultant to the White House Medical Unit. And some of us have read his book and have learned from him in various fora. So thank you for joining us, Greg. The second speaker is someone I've known for many, many years, Dr. Abdus Salam Khan. He is the current president of the Pakistan Society of Emergency Medicine. He's director of emergency medicine at Shifa International Hospital in Islamabad, Pakistan. He's also leading the fellowship exam at the Pakistan College of Physicians and Surgeons, CPSP. Abdus Salam has been a leader for us in emergency medicine in Pakistan, and we are fortunate to have him speak to us about leadership today. Thank you, Abdus Salam. So let's have the first talk. So Greg, over to you. Please go ahead and share your screen, and we'd love to look forward to listening to you.
Okay, well, thank you. Thank you so much, Junaid. Thank you for inviting me to this important discussion and also this prestigious panel as well. I'm honored to be a part of this. Allow me to share my screen just for 1 minute here. Okay, so I'm just going to take a brief moment to give you some overview on a topic in disaster medicine that we discuss frequently called crisis leadership. And, you know, we talk a lot about how disasters differ so much. And we use the phrase, if you've been to one disaster, you've been to one disaster. But the one thing that is consistent throughout most crises and disasters is the idea of crisis leadership. So this will be a broad overview. It's going to be brief, but just to give you some of the salient points that I've learned in crisis leadership. So we are all living on a global scale, probably the greatest healthcare threat, at least in the last 100 years, which means in our experience, it spans beyond healthcare to economic crisis and just really a social concern as well. So what we're experiencing now is truly unprecedented in our lifetimes. So it really demands, I think, a number of different actions. Most importantly, it demands crisis leadership. It demands leaders and people that we look to provide guidance to perform in a certain way. And it's an important way that they do that. So let's take a quick look at what's going on right now in this crisis. And essentially, we are in that period now of time around the world where either countries are fully engaged in the response. Some are coming up over that peak and coming down and actually starting to recover somewhat, or other countries are in that preparedness phase where they haven't quite gotten the surge yet, but they're preparing for it. One of the most important things that we're trying to understand right now is the idea of social distancing strategies, and when do you trigger them? And then now in some places, including here in the United States, how do you down-regulate them? And this is not an easy thing to do, and it's not really something that has a historical precedent as well, where these are sort of uncharted waters. So we're trying to figure this out as we go. This is a quick look at some of the countries and how they're doing with the social distancing strategies. After a point that we consider a threshold of 2 deaths per million, seems to be at that point where the curve begins to sort of take off at an upward angle. And you can see some countries are doing better than others. The lowest line there in green is the Czech Republic, who've been doing a really terrific job with social distancing strategies and isolation, and particularly wearing masks in public. And other countries are struggling a little bit more with this. But if we get beyond COVID-19 and just talk about crises in general, we have to talk about that idea of a leader and a crisis leader. So what is a crisis leader? Well, leadership demands certain skills in all aspects of leadership, everyday leadership, management, certain skills. But in a crisis, it's important to above and beyond the typical leadership and management skills, to have something that is that much more, and it's also an important piece of it. The most important thing I think a crisis leader understands is that he is not alone, or she is not alone. A crisis leader, rather than standing alone, needs to lead a team in a very important time where time is of the essence, and decisions sometimes have to be made very quickly, and that's not necessarily with as much information as you might normally have. So a crisis leader leads a team. And if you think about leadership in general, what does that mean? What does that team mean? And we use a term at the NPLI called meta leadership. And the idea of meta leadership is that you not only lead down to the people that report to you, let's say, or your team, but you also have to lead upwards to those that you report to. So we see a prime evidence of this with Drs. Fauci and Birx right now in the coronavirus task force here in the US. And they are really being asked to provide their expertise and lead us from a healthcare perspective through this crisis by leading up, by essentially leading the president and others in the who are in the government leadership of the country. In addition to that, we have to lead across to other agencies, and then we have to lead beyond. There are arcs of time in different crises, and these arcs of time come and go. And we have to understand in a crisis such as this, where we can't really see a clear endpoint, that our leadership is going to have to go beyond today, beyond next week. And it may be that we don't actually understand and see right now what that horizon is going to look like. What is the finish of this going to look like? And then post finish, that recovery period, what is that going to look like? So it's the idea of meta leadership that we like to talk about. And then crisis leadership, again, it's typically or always done in a situation where there's some sort of high risk environment happening. And by definition, crises are these low frequency yet high acuity events. So they don't happen often, but when they do happen, they can be catastrophic. So training on these crises is extremely important. And you have to understand that sometimes, not always, but sometimes you have very, very short time to react and to make leadership decisions. And again, you may not have all the information that you need when you're doing that. So what is the overall goal in a crisis? Again, by definition, a crisis or a disaster is chaos. So the overall goal, particularly on the short term, is to create organization from that chaos. And how do we go about doing that? Well, a crisis leader and a disaster responder has to work within the framework of something called emergency management. And what exactly does emergency management do? Well, emergency management is that structure under which we all operate during a crisis that attempts to bring that chaos to some degree of organization. And emergency management really needs to be implemented and operational until the point where the situation comes from the chaotic part of the crisis or disaster to what essentially resembles what the norm was before the disaster. And that's when you can take emergency management out, and it can no longer does it have to be operational. It can just be in the preparedness phase. So if you look at the leadership continuum, leadership management continuum, you have on the left side of the graph here, you have typical leadership everyday management where you're going through operations, logistics. This might be leading a hospital, leading a company, leading a government, a country, but you have relatively predictable steps that you have to take in leadership and management. You typically do have enough information to make those decisions. You go to the right of this graph to where a crisis happens, and that's where you need to have, because you don't have all of those things. You have some ambiguity, you have some risk, and you don't have all the information. This is where you have to adapt. This is where crisis leadership comes into that phase where you have to pivot essentially instead of the typical leadership that you see. So crisis leadership in this COVID-19 period, it's all of these things. What are some of the crisis leadership decisions that are being made now? Well, for instance, how long do you have before deploying these non-pharmaceutical interventions? So before we start implementing isolation, what period of time, is it that we trigger those? And this is early on in the crisis. Here in the United States, this period of time is probably sometime in February, if not late January. In other countries, you're probably just entering this period of time now. And a crisis needs are getting progressively worse. Sometimes you're operating without data-driven information. The whole thought about hydroxychloroquine over the last month that really wasn't data-driven is now proven to be false, as an example of that. So there's also, it's a dynamic situation, and there's the idea of not only just is healthcare being affected, but the economies are being affected, society in general is being affected. So again, how do you balance that? When in this crisis do we start down-regulating these non-pharmaceutical interventions? So this means that because these mini crises, these arcs of time are coming at a crisis leader at different times during the disaster, we have to learn to pivot as opposed to, let's say, panic. So briefly, when we see a crisis, when we're in a disaster as a leader, we know that there are the known knowns, those things that we know and we know them, the known unknowns, those things that we know that are unknown, that we don't know them, the unknown knowns, and then the unknown unknowns. And of course, the unknown unknowns are the ones that are most troublesome. Those are the ones that you're not predicting, and they come out of nowhere, and really when you have to pivot. So again, briefly, some of the issues a crisis leader has to deal with is the idea of you don't have the full scope of the situation. So for instance, this is a quick snapshot of the Boston Marathon bombing. Let's say the situation is this entire picture, this entire screen, but if you're the crisis leader, especially if you're remote from the scene, your picture might actually be this. The information that you're getting only allows you to see this much. If you understand that, if you know that your information is limited, you won't fall into that panic mode, and instead you will be able to make decisions based on your limited scope of the situation until you get a full view of the situation, and then manage and change those decisions as needed. So you have to understand as a crisis leader the scope of the situation. You may not have full access to that. You might not have full optics of exactly what is going on, yet still have to make some decisions. The other idea is this situation of the dilemma of the cube. And this is an idea about the information that you're getting, let's say, from the scene of a disaster, or in the cases of a crisis like this, from the different parts of your country, your hospitals. What information are you getting? Well, you have to understand that, particularly in the early stages of a crisis, that information might not be accurate. And it depends on the point of view or the optics of the person who is giving you that information. So for instance, here we have a cone in a cube. And we have, let's say, responder A, who is coming back to report to you as a crisis leader, is looking through peephole A. And then responder B, who's also going to come back and report to you, is looking through peephole B. Well, what happens in the situation when they come back to talk to you? Well, responder A is going to come to you and say, Dr. Ciottone, I know what's going on. There is a triangle in the cube. I've seen it with my own eyes. This is the situation. It's a triangle in the cube. Whereas responder B is going to say to you, Dr. Ciottone, I've seen the situation. I've been on the scene. I know this is a circle in a cube. I'm confident it's a circle in a cube. Trust me. Well, the reality is it depends on their perspective. And actually, it's neither one of those is correct. There's not a circle in the cube, and there's not a triangle in the cube. There's a cone in the cube. And this is an example of understanding that depending on the perspective of the information being reported to you, it may or may not be accurate. This has to be something that you keep in mind as you make decisions as a crisis leader. So to finish this brief overview, the keys to success, I think, in this COVID-19 crisis are to collect the data, analyze it, and understand it appropriately. And then take that data and that analysis that you know, understanding that there may be some unknowns as well. We're going to learn more information as we go forward in this crisis, but take what you have and make informed decision-making criteria and steps that the country or the organization is going to take at that point, with the understanding that you might have to pivot and change those decisions. Public education, particularly when you're talking about community mitigation, which is what we're doing now, is exceedingly important in a crisis like this. We're no longer taking care of individual patients. This is not a disaster where there's a big car accident or there's an explosion, and we're taking care of individual patients. We are taking care of communities now. So it's not up to individual doctors and nurses to take care of communities. It's the community. You have to educate them appropriately so they can make these decisions. Press management is very, very important. The press can be helpful. It can get very useful information out, but we have to block this urge to have sensationalism. There's no role for sensationalism in a crisis like this. And finally, the most important thing a crisis leader can do is to pivot and not panic. Every disaster is going to take a turn this way and that way and continue to do that till the end. If the crisis leader can learn to pivot with that disaster as it goes, he or she will be much more successful. Thank you.
Thank you, Dr. Ciottone. Now I'm going to request Dr. Abdus Salam Khan to take us through his slides and share with us his perspective from an LMIC institution.
Thank you, Dr. Junaid. I hope you're able to hear my voice.
We can hear you. Yeah, but
let me bring my slide to the front.
Greg, you'll have to unshare. I think that might help him.
Yeah, let's see here. Seems to not let me get into that.
I'll do it.
Yeah, no, I have it there. Okay, good. Thank you.
Okay, let me see if I bring my slides up. Okay. Can you see that?
Yeah.
Okay. Okay, I'm going to be brief also, like Dr. Ciottone, so you guys won't be bothered with too much information. Basically, coming from a lower middle income country, we are trying to catch up with the big guys, and we are trying to do a lot about emergency medicine in Pakistan. And we wanted people's attention, not this way that we are getting now. So I'm going to go through some of the numbers first. The objective of my talk for today would be give you some background of what's going on as far as the emergency medical care goes in Pakistan, challenges during the onset of the pandemic, response of the leadership, lessons learned, and looking ahead beyond COVID. So the background is not all COVID, but I thought this picture probably would put some background to it. So the population of Pakistan is 192 million, a little bit over half of the population of United States. We have a number of registered medical practitioners in the country of about 188,000. Number of registered specialists are about 46,200 about. The physicians per 1,000 population is about 0.9, as far as in USA is 2.3 per 1,000. Estimated number of hospitals in Pakistan is 1,167, more or less. Hospitals attached to the medical school is 214, in which 78 are public institutions and 136 are private institutions. Institutions involved in residency training are about 11. And that's the backdrop I wanted to give to everyone that facing this pandemic, this is the resource that is the educated, or you can call it the trained resource that we have, is only coming from 11 institutions, and it has to cover this much canvas. So what challenges we face with this small group of people? National level and at the local level. National level, as far as everybody was going through information overload without a clear direction. So one day you're waking up and going to the hospital and everybody's saying one thing, and the other days everybody's maybe opposite, or a clear disagreement in which direction we are actually going. Then there was an ill preparedness in as far as the equipment goes. So there was a big hue and cry on, okay, we are not very much equipped as far as the PPE goes. And then people didn't have much idea what PPEs to use in which kind of circumstances. So there was some overuse at one end, and there was some underutilization at the other end. And that led to some disasters locally with some people unnecessarily getting exposed to the COVID, where they could have avoided the circumstance by actually getting prepared properly. Most hospitals lack supervised care at frontline. As I showed the slide, out of 214, there are only 11 institutions that have a residency program. Rest of them are going with the care with people who are either not trained or not supervised. So there were pockets of good to great care in the hospital where EM training was delivered. So coming to the local levels at each individual hospitals, including my hospital also. So the thing that struck me the most was abrupt change in the focus of the hospital to the ED. So when the people started realizing that they are facing a pandemic, and they started shutting down different parts of the hospital for not getting exposed to the COVID patients unnecessarily. So everything started coming to the emergency department. And we had to come to the speed very, very quickly to make sure that when we do anything, that has to be safe as far as we are concerned and as far as our patients were concerned. So there was information overload, lack of preparedness for the pandemic, and then the anxiety over among the ED staff, because their families, they themselves and their peers, they felt that by virtue of working in the emergency department, they are more prone to get infected with the COVID, and that at that time when it was all starting, it may be a death sentence for some of them. So what did we do? At the national level, I think I can say for sure that we didn't back off, and we rose up to the occasion and took the task like everybody else in the world did. The emergency departments took the burden and then dealt with as much competence as they could. And they gave a very good response in my opinion. Despite lack of preparedness, a very safe response was provided. Although I was looking at the data yesterday, there was like 25% of the affectees in Islamabad area are physicians. So it's a very high number. Nonetheless, we still dealt with it with minimum sort of exposure as it was possible. Then we started creating some togetherness, utilizing available digital resource. So we had some groups, some chat rooms, some here and there. We started like talking to each other. We started forming groups, sharing knowledge, coming up with strategies, looking at what people are doing, what is working, what is not working. And unfortunately, usually our stance is just to see towards UK or the USA and copy their, whatever they are doing, we tend to copy it. But this time, copying UK model was not very desirous in the mind of plenty of people. And the same thing goes as far as the New York goes. Rest of the USA probably is a little bit different, but nobody wanted to copy what happened in New York. We try to come up with a common response and so that we can handle it in as efficiently, as safely as possible. I don't know, it is still going, so we still have to do some catch up, and we have to tailor our response in a more effective way. Locally, what we did was quick realization of the new role. So we were involved in all the decision making from the emergency standpoint. Talking to my own department, we saw that there was some fear, and we told them that rather than living in fear principle, we should live in the safety principle. So we have to make sure everything is safe. Fear has to have some place, but not the driving force behind every action. So the first thing we had to do is to readjust patient flow to provide safe care to the patients. And we realized that during the COVID, people still get sick from other reasons, We have to make sure that they also get treated in the emergency department. While the other places in the hospital were shutting down, we were the one who had to take that brunt also. So what we realized is that the junior staff was looking for some direction. And if we don't communicate with them frequently, addressing their clinical as well as non-clinical issues, including their personal issues, including their family issues, including their psychological and other issues, we won't be able to get the proper response out of them. Rallying the whole hospital to help the ED in day-to-day functioning. So Dr. Ciottone was telling about different kinds of leadership response. That we had to do that also to present to the whole hospital what we actually need and how they can help us. So what are the lessons learned? I will be very quick in just giving you these lessons, and then we can talk about them when in the question answer session. The first lesson we learned is that our best asset was a realization that we were always ready for unknown. And that's we are good at. So while doing the emergency medicine, we always face this unknown on a daily basis. This unknown was a global phenomenon, but our unknowns are the daily patients who come with the complaints that usually we have to sort them out, which is different as compared with all the other faculties in the hospital. And then we also realized that when you have to deal with the unknown, always fall back to the basics. So if you have your basics covered very well, probably you won't be too much away from the actual saving yourself during this kind of a catastrophe. Teamwork has no match. That was the third lesson that we learned. A best way to survive is to adapt to change and match the speed of the change. So we not just have to change, but we have to match the speed. The way that the things are changing, we have to match the speed. People will always perform better if properly appreciated. This is what we saw on a daily routine. Our juniors rallied behind us when they were properly appreciated. If we neglect them, we cannot expect them to perform better on a day-to-day basis. And then this is for my residents. If we have trained them well, then at times leave them alone to lead. They will amaze you because they have learned a lot from you and from the circumstances. And if you let them lead, they will do wonders like you expect them to do. So what is beyond COVID for us? We were just talking before this presentation with Dr. Junaid, what would be the future of emergency medicine? Would we be getting the same attention after this COVID is done, or would we be back to, well, who are you? So I think we have a chance ourselves to realize this phenomena, this momentum, use this momentum, and further our agenda of establishing emergency medicine training in all the emergency departments across Pakistan. Beyond COVID, safety principle has to be the guiding light all the time. Creation of a national body quickly to provide centralized guidance for the frontliners. Need to establish ED registry, which is established across the globe, but we are sort of lagging behind in that. And we have to come up with digital solutions, including telemedicine. Public education to make them partners in care. This is what we saw during this pandemic, is that the public is not our partners at this point in time. So rather than taking it as a negative, we should convert this into positive, and we use the public education to make them our partners. And the last thing, this is my hope, that this pandemic should create great EM leaders in Pakistan. So that is from me, and we can continue with the question answers.
Thank you, Dr. Salam. I have a couple of questions on the chat. You guys can also see, and I'm going to. There's one question which is more generic, and this question is from William Emerson. Why is the pandemic so great? And there are many reasons, and I guess one of you can address that in your answer. But I have this very interesting question from Dr. Abubakar Sheikh, and it is for Greg Yu. Why is COVID leadership vacillating or confused about the nature of threat, whether it is primarily culture, health-related, or economic? Secondly, is it not the primary function of leadership to assess the duration of the crisis? You're mute.
Sure. And the answer to the first question is the reason is because it's both. It's both a healthcare cultural crisis as well as an economic crisis. And the answer to the second question, very briefly, I think, is because nobody can see the end of this. This is unprecedented. Nobody quite knows how this is going to go from next week to the end, what that end is going to look like. To answer the questions directly, for those two reasons, I think this is why some leadership seems to be in a little bit of a disarray in how they're addressing this, and sometimes saying one thing and another day saying another thing about how we're going to do this. My personal opinion, however, if I were to predict what we are going to be facing in the coming months, I think is the realization that this has been a healthcare crisis. It's been a healthcare crisis for the last 3 or 4 months. Now we are creating, essentially, by treating the healthcare crisis, we are creating an economic crisis. And the reality is, the world, certain countries, I can tell you, my country cannot continue along in the way it is right now for very long without having a catastrophic economic crisis. So there has to be a balance between the two. I can't tell you, I don't know exactly what that balance is going to be, but I can predict that I think leadership is going to balance it by doing a graded different downregulation of the self-isolation and the social distancing strategies that are going to allow some people to get back to work, meaning economies start, but protect others. Excuse me. If you look at the case fatality rate for COVID-19 in the different age groups, from age 0 to about age 50 to 55, the case fatality rate is actually quite low. It approximates influenza. For the younger ages, it's about 0.1 to 0.2%. It gets a little bit higher than that as you go forward, but up until about age 50, case fatality rates are fairly low, similar to influenza. You get beyond age 50, 55, and the case fatality rates go up with age and also with comorbidities, to the point where if you get to about age 80 and above, the case fatality rate is around 17 or 18%. Excuse me, that's quite dramatic. And I think what we're going to do is, in order to address both crises, the healthcare and the economic, I think we're going to slowly allow the younger population to get back to work. Again, continuing with social distancing practices like, maybe wearing masks over your face, different personal hygiene practices, but allow them to get back to work so the economies can start getting back to normal, while at the same time protecting the vulnerable population. So essentially keeping that vulnerable population, the older and those with comorbidities, probably still in the kind of isolation and the lockdown, as we say, that they're in now, to really protect them. If I were to predict what the future is going to look like, I would say that's probably going to be it, so that we can address the healthcare crisis as well as the economic crisis. And this, of course, is to bridge us to the point where we get a vaccine or very good therapeutics, or both.
Thank you. The other question, I think you partly answered from Amjad Ali Shah, and he is asking, where do you go from here? Who you think we could follow to stay safe and resume our normal lives? At this time, everyone seems to be in chaotic situation with no clear vision, particularly at the government level. Abdus Salam, you want to share your thoughts?
Yes, because for us, I think we can feel it more than anybody else can, because the whole country, I think, lagging behind in a lot of education as well as realization about this pandemic. And you have too many people talking too many different kind of philosophies, and they are all conflicting. And for the healthcare practitioner in the middle of this chaos, needs to make some sense for the whole country. I think this is more than we expect them to do, but still trying to make sense of all these situations. I know that what actually so far in 4 months of the knowledge base that we have created, we know that we don't have any sort of like vaccine or medication available. So how do we go about it? The best thing still has to have the social distancing and the other basics. As I said in my slide, if you have to deal with the unknown, go back to the basics. Basics is that you use your mask, you use your social distancing, and you use the safety of the of yourself by doing frequent hand washing and other things. Now with that, how are you going to run the daily business? It's going to be tough, but if your population understands the philosophy, I think you would do okay with these social distancing and the mask and the hand hygiene.
Great, thank you. There's a question about rehab. You know, we have focused so much on the acute response, and there's a good reason for it. However, as these patients, many of them requiring ICU, prolonged stay in the hospital, start to get better, they will require a prolonged rehab. Is that something, at least in the US, Greg, is that the focus of current response? Is that something people are talking about much?
Well, you know, there's going to be a number of, I think, consequences to this. People who recover from this do require rehab. And, you know, if they're depending on age and their comorbidities, that rehab might have to be in a supervised rehabilitation center where you also have other issues around the social distancing strategies, or it might be at home. So that's part of the picture. You know, we're again, this is all new. We're just having people now start to recover from this disease. So how best to treat them after recovery, you know, we'll be defining as we go, but that's certainly a part of it. You know, there's also going to be something that we never should overlook, and that is the psychological rehab from this as well. Not just from patients who get it, actually even more so from patients, from people in the community who have either gone through the psychological trauma of losing a loved one. And of course, in these circumstances where you lose a loved one, you probably were not able to be at the bedside when you lost that loved one to provide that love and support. You probably were not able to actually give a proper burial because of the unfortunate social distancing strategies that we have now. In addition to that, it may be that you've lost your job. So economically, you're having a personal disaster as well. There's going to be a lot of psychological effects from this that we also have to deal with in a recovery phase. Healthcare workers as well. You know, healthcare workers who have been in the heat of battle, you know, in the hot zones like New York City and Italy and some others, you know, they're going to be having a lot of psychological follow-up and rehabilitation requirements as well.
I think I agree with Dr. Ciottone, and we have seen this. I would talk a little bit more about the healthcare worker psychological rehabilitation part, because the other rehab, I don't think at this point in time in Pakistan anybody's talking about it. So, and we are still in the earlier part of this pandemic as far as the Pakistan goes. So maybe in future we have to look about getting the rehab for those people who are affected. I think the local leadership has a lot of role to play in keeping the psychological health of their healthcare workers intact. Just give you an example, my hospital wanted to have psychological sessions of the healthcare providers, and they asked the emergency physicians and the nurses to give their names who wants to speak with the psychiatrist. And none of them opted to do that. They said, our leadership is keeping us enough busy as well as giving us enough psychological support in terms of being there. So the leadership role can also help the people not go into that trauma of seeing the death on a daily basis, seeing the people in disarray, in chaos on a daily basis. And I will tell you that we are seeing in general public, we are seeing the trauma already coming to the hospital in terms of people getting very, very anxious, presenting as all the COVID symptoms, but they are like psychologically distraught. One of them started like shouting in the emergency that this is sort of like a conspiracy, and I know the people are after us and they're gonna get us. There's no escape and stuff like that. So you would have plenty of people if you lock down people enough for a longer period of time. So besides the economical crisis, it's going to create a psychological crisis all in the country if we keep locking down for a longer period of time.
Yeah, I have a couple of questions from Dr. Murad. One is about Pakistan, and it's about the complex hybrid healthcare system we have here, private sector, government, NGOs. And his question is, what is the role of leadership in streamlining these different entities? Who would pay for the treatment of COVID patients? Given this a highly contagious communicable disease and a serious public health problem, in a complex health environment where a lot of people have to pay out of pocket, who will cover their cost?
Okay, as far as the Pakistan goes, I think it's a very interesting question because we don't have a real healthcare system where there is one pair or two pairs or multiple pairs. We have a system in which there's a government entity, there is some sort of insurance, and rest of it is out of pocket. So if you get sick, this is entirely up to you and your family to come up with the expenses. And when we are talking about, say, for example, the breadwinner of the family gets sick and he has to go through the rehab, so you can start realizing that now the economic cycle is stopped for that particular family because the head of the family is sick, and then he has to go through the rehab, he or she has to go through the rehab and spend their own money, their savings, to get better, if at all they get better. So it's a complex situation. I think part of it is addressed by the government, but I don't know if it's that coordinated or not. And part of it is getting picked up by the NGOs, different NGOs. And I have seen different sort of telemedicine options available to the general public for free. I know for some of the hospitals, they have offered these services, but these are paid for. So you have to pay and get the services through telemedicine. My hospital is doing it, and I know a couple of other places are doing it, but this is for profit. Some of the NGOs have set up some lines that are free for everyone. They can dial in and they can speak to some specialists, some general physicians and stuff like that. I know that this cannot meet the need of the community, but at least this is something that we can look for to expand on it, and hopefully we may be able to serve our community better.
Thank you. Greg, I have two questions for you.
Yep.
One is more, the U.S. health insurance system and a disaster like this where you have a lot of people without insurance, and then what is the response of the U.S. Healthcare system? And the other one is from Dr. Abubakar Sheikh about minorities. We have read about Hispanics, African Americans in the U.S. being more affected. Is there a socioeconomic reason? Is there a biological reason? Dr. Your thoughts.
Yeah, well, both questions are very interesting and difficult to answer. But, I can say in general, crises and disasters, will expose the vulnerabilities in this case, in your healthcare system and other vulnerabilities as well. We've been wrestling in this country for years now about the right kind of universal healthcare that we need to implement and provide. You've heard about the Affordable Care Act, all these different programs that we're implementing and then changing and then maybe talk about taking down, and we haven't quite settled the issue yet. So when you know, and that's in normal times. And when a disaster comes or a healthcare crisis comes, you know, that exposes some of those issues and vulnerability. So I don't have a good answer about the insurance one yet. I'm sorry. I think that we're going to be seeing some things, both economically, you know, you've already seen the stimulus package and some others coming in the near future during this crisis. There's already been some modifications with insurance coverage, and that you know that in reimbursement, you know that telemedicine is now playing a big role in the response to COVID-19 in the U.S. and also a number of other countries around the world. You know, there's starting to be better reimbursement for telemedicine visits versus what there was before. So again, this is all evolving, and I think things are going to be changing. So I don't have a really great answer for either one of those questions. All I can say is that this is one of those things I talked about in my presentation, where you have to learn how to pivot as these new issues and new sort of unpredicted consequences come your way, and you have to make decisions on them. It's part of crisis leadership.
Let me ask you one more question. Is part of it is being asked here, but I'm going to expand that a little bit. How do you keep the morale up for your teams? That's one. But how do you keep the morale of, if you're the leader yourself? What are your choices? You know, this is a prolonged disaster. It has huge mental health consequences for the leaders themselves. They can't show their vulnerability. How do you deal with that in a crisis like this? How do you prepare yourself?
That's a great question. I, as I'm sure many of you on the panel, as well as the listeners, have been in situations as a crisis leader. I was one in 9/11, and I've been in some other situations the same way. And you know, a crisis like this is different. A COVID-19 crisis. It's one thing to be a crisis leader where you are addressing a problem somewhere else. You're being brought in, or you come in with your team or with whatever it is to address a problem here in this area that this community is having. Whereas outside the community, it's relatively normal, but we're addressing the disaster in this community. This is different. This disaster is everywhere. It's not like we can rely on our neighbors, or in the case of the United States, a neighboring state or neighboring region to come help us, because everybody's in it. And it's true globally as well. So when everybody is in it, and you as well as a crisis leader in it, you have a lot of these issues that go, you know, in your mind, in your personal life, at the same time while you're trying to be a crisis leader. How do you prepare for it? There's no great way to prepare for it. I guess just understanding that there's a role that you have to play. Understanding that you do your best to control and make better the personal situation you're in for yourself and your family. But in the end, if you're leading a team, if you're a crisis leader that others are relying on, you need to put those issues, those personal issues, as I say, you need to put them in a box and put the box away, and not really let that hinder the way you're going to make your leadership decisions. It's not an easy thing to do. It's compartmentalizing, as we say, and it's a difficult thing to do. But the more experience you get at it, the more you're able to master it. Yeah. That's about the best answer I could give you.
Thank you. I have one of our participants who would like to see if I can get him to say a few words.
Well, you're talking about Dr. Murad?
Yeah.
I would love to hear from him.
Yeah. So Dr. Murad, see if I can, yeah, I think you're on, if you can say a few words.
Hi, can you hear me?
Yes. Can you introduce yourself, sir?
So I'm Dr. Murad Khan. I'm a professor emeritus at the Aga Khan University Department of Psychiatry. And currently I'm in Edinburgh in Scotland, where I came here for some personal reason. I kind of got stuck here. So I'm calling in from there. I've been really interested in organizational ethics for a long time. I've been researching this and talking about it and writing about this. So it really, when you talk about leadership and you talk about leadership in a emergency situation like this, I totally agree what you've said, Dr. Ciottone. Sorry if I don't pronounce your name correctly. But I really feel the elements, the attributes that you really require more so now than at any other time are things like communication, transparency, honesty, integrity, moral courage. It's very important. And really doing your best, like you've said. So these are really should be the guiding principles. And other than that, obviously, you know, the facts, the information as they come through, and really trying to work within the constrained resources one has. I know what the situation in Pakistan is like, even in normal times, and under these really severe situations, it must be completely overwhelming. So, but that, I think those are very important things, and leaders need to keep reminding themselves and keep revisiting these important principles, so that they don't get sucked into the crisis that you know, the staff must be facing. Thanks.
Thank you, Dr. Murad. This is very helpful. I'm going to have a couple of more questions which are about the role of nursing and the role of medical students. You know, there are two questions about that. Both from, I'd love to hear from both the panelists of what you think about how do we strengthen nursing in terms of a disaster response. And also in many places in the world, including Hopkins, we have removed our medical students from the hospital for now. Should we allow that? I mean, there are reasons for it, but how do we train the future leaders if they're not exposed to the reality on the ground?
So let me go first. This is what we talked about this morning in our daily briefing that we have in the hospital about the nursing, because with this thing, there were a lot of jobs open for the nursing outside Shifa, and a lot of nurses started leaving. And then at the same time, there were plenty of nurses who were getting exposed, and the nursing cadre started getting low in the number. So we had to bring in the College of Nursing principal to the meeting, and then we asked them the same thing. If we can ask the final year nurses to come and start doing their clinicals as well as the routine care for the patients, because the number of COVID individuals are increasing in the hospital, and slowly the country is opening up. So the number of patients who are non-COVID are also going to increase. The burden on nursing will increase. So we have to cater to that. So this idea was catered to, and I think was appreciated by all, although it's going to be a challenge that in this difficult time, you're relying on the less than able sources who have no experience coming to see the patients who are the most vulnerable, who will be the most vulnerable. But there has to be some way in which you let them catch up for some time, and then you utilize them with some sort of like safety principle. And I think then they will do good.
Yeah, I don't have much to add to that. I think, you know, for nursing obviously is an extremely important part of our healthcare force, and we need to protect, you know, nurses as we do doctors and others in the healthcare force during this COVID-19, and so that they're preserved in their ability to care for the patients. You know, medical students, I'm a little bit torn on that. I agree with what Dr. Abdus Salam was saying. I think that, you know, medical students are our future. They're the future doctors. They're going to be dealing with the next crisis that comes around, you know, hopefully years from now. And then, you know, this is invaluable experience. We have a phrase, you know, don't ever let a good crisis go to waste. Meaning, let's learn as much as we can from it. And that includes, you know, lessons learned, meaning what we did not so well, we can do better in the future. But it also means educating, you know, our future responders from the healthcare side, you know, the medical students, the nursing students, et cetera. So I think that if we can balance it in a safe way, I don't think we should necessarily be removing medical students from the hospitals. I think that, you know, we engage them. Again, you know, we don't put them in very dangerous situations. But, you know, before COVID-19, there were other dangerous diseases that we deal with all the time. And, you know, we didn't pull medical students out during those times. So I think that there's a balance between safety, which I always think is important, but also the learning opportunity. So.
Yeah, great. I have a question which also Dr. Maliha asked about the morale, but I'm worried about situations where the frontline healthcare workers do not agree with leadership, and they see the problem and the solution differently than what leadership is trying to convince them of. And we are seeing in many places the frontline doctors, nurses walking out or threatening to walk out. Uh, what what is the problem there? Is it a leadership issue? And is it communication? Is it trust? And how do we handle that?
The answer is yes. It's all those things. I think it is a leadership issue. I think both sides have to understand. So the frontline healthcare workers have to understand that they don't have the full perspective. That yes, they're in a very, very dire situation, very difficult situation, and they are on the front lines, and they can see the front lines better than others. But you also have to understand that leadership, if they're performing properly, has a larger picture. They have to balance not only the frontline situation, but all the other parts of this crisis, especially in the COVID crisis, where there's not only the healthcare issues, but there's the societal, cultural issues, there's the economic issues, and everything else. A good crisis leader in this situation would do all the things that you said, would communicate better. If I was a crisis leader and I had an issue, or somebody had an issue with me who was one of my, let's say, frontline workers that I'm leading, I would go and engage them directly, engage the group directly, and say, okay, let's talk to each other, let's explain each other's situation. Communication is very, very important. And in order to be trustworthy, as you said, to build that trust, you have to have everything that Dr. Murad said, which I completely agree with as well. You have to have the honesty, the integrity, you have to communicate directly. Listen, in a crisis, it's not always good news. If it's not good news, relay the fact that it's bad news. Say, I have some bad news to say. This is the situation right now. But you know what? It's bad, but this is what we're doing to deal with it, and we will get through it. Always provide hope. There always has to be hope when you're dealing in a crisis from a leadership perspective. We will get through this. It's bad times now. This is what we're doing to address those bad times, but we will get through it. All of these things come together, I think, to solve the problem that you're alluding to.
I think I agree with this. And if I want to add a little bit, I would say the middle leadership has to play the double role. They have to make sure, like say, for example, at my level, being the director of emergency part, I have to make sure that the concerns of, I have to make the hospital understand the perspective of the frontliners, and we have to come to some negotiation, some middle ground. Probably we may not be able to solve all the problems that are faced today. And whenever we make a guideline, with this pandemic, what we had to learn was, what quickly learned was, you cannot make a rule that that's going to last more than 24 hours, because the very next day probably is going to change. So how do you communicate that? And as well as if that rule is going to be seen as something that's a hindrance or something that is going to facilitate the work of the frontliners. So when we started this, everybody was shoving everything to the emergency department. Okay, you're going to do the nasal swab also, because nobody else probably knew that. They said, well, we're going to send the patient to the emergency department. And we had to put our foot down and say, we cannot take it no more. But the thing was that the first test that they did was done by myself, because I wanted to make sure that my staff would understand that in terms of crises, they have to do the things that otherwise they probably will never do. So we made sure that they understand their part, that there is some expectation from them. So when you negotiate, you just can't come up with your own ideas and trying to implement on the larger body of healthcare, the whole hospital. So you have to give them some sort of like things that, okay, we're going to offer you this. What are you going to give us in return? A good negotiation probably will keep everybody happy.
Great. Thank you. We actually are 1 minute over time limit. I'd like to thank you both for running such a great session. I think it was very, very useful. And thank you all the participants who participated, who asked questions. And I'm sorry if we didn't respond to any of your questions. We tried to address as many things as possible. So look out for the session next week. Hopefully you'll see some of you and actually all of you and many more. And thanks again. Look forward
You're
to seeing you
welcome.
again.
Thank you. Yeah,
And have a good afternoon.
Okay. All right. Bye-bye.
Bye-bye.